Welcome to the Generous Benefits Podcast, where we help employers create meaningful people-first benefits that make a real impact. I'm your host, Amanda Brummitt. Today, we're explaining the value of direct primary care with Beth Holmes, Vice President of Hint Connect. If you're curious about what DPC is, how it fits alongside a health plan, and what it really takes to roll it out well, including budget, contributions, and a communication plan that drives adoption for on-site, remote, and multi-state teams, this conversation is for you. Beth, thank you so much for being here today. I'm so happy that you're here to be able to explain a little bit more about direct primary care. Anybody that knows the Generous Benefits team knows we're passionate about it, but I'd love for them to hear it from somebody besides us.
Well, thanks so much for having me, Amanda. I met you guys. I think you were one of the first teams that I met when I started at Hint, and I was bringing the idea of direct primary care to brokers, and you gave me some early feedback even before we created our product. So I'm really glad to be in this position all these years later, talking to you about kind of where we're at now.
Yeah, definitely. Well, before we dive into DPC, tell us about you. Who are you personally and professionally?
Well, I'll start by saying I am a mother of 2 young daughters and a very old dog. Me and my husband and my family live in the Bay Area, California, but I'm originally from the East Coast. And I've been working in the healthcare space to age myself, over 15 years now. And I've always been interested in how payments influence care. And so I started my career early on working in value-based payments, both on the contracting side and provider performance management under risk contracts at various insurers. And that was a little bit demoralizing because we all went in with really good intentions with pay for performance, risk-based contracts, thinking they could really influence how doctors were taking care of patients. But from where I sat, we didn't really see those results. And so when the opportunity to work at Hint Health with direct primary care doctors arose, I was ready for something new. And I found this great little sector in the healthcare system of doctors and other clinicians who are really just trying to provide the best primary care possible to people, individuals, families, companies. And it's a really great space to be in. So on my team, we work to have employers connect with direct primary care practices, DPCs. I'll say DPC instead of direct primary care, if we're going to get into acronyms already. DPCs typically work both one-on-one with individuals and families. We call that retail. And then they also often sell through employer channels. And so what my team does is help those DPCs work with bigger employers and more spread out employers because the DPCs are typically not in an insurance network today. So that's who I am and a little bit of what I do. If there's anything else you're curious about, feel free to ask.
I do want to ask about the old dog and hear the whole story there, but I also know our listeners are pressed for time, so we'll talk about the dog offline.
Yeah, well, she's sitting at my feet, so she may make an appearance at some point in the next half hour. We'll see.
Perfect. So tell us the difference between direct primary care and traditional primary care, and also why you think DPC is growing.
Yeah, so traditional primary care is what we would call fee-for-service primary care, where doctors get insurance payments to see their patients in a primary care setting. And those appointments typically last between 8 and 20 to 25 minutes. In the traditional primary care system, there's been a lot of changes in the past 10 years where more of these doctors are owned by hospital systems or by private equity or large companies. And so whereas a lot of primary care doctors used to be independent, own their own clinics, have small clinics, now the majority, over 75% of them, are corporate owned. And the impact of that when we compare fee-for-service primary care or traditional primary care to direct primary care is that typically there's shorter appointment times, long waits to see primary care doctors. There's a whole lot of administrative work that's required in primary care today. So that's why when you go in for a visit, usually the doctor's just typing away while they ask you questions over their back. So that experience, I think, has has gotten worse over the years. And what we see is a lot of doctors not even wanting to go into traditional primary care. There's about 1,000 unfilled residency slots every year in primary care specialties because it's not the place to be if you're a doctor. It's a really, really tough job,
Yeah.
especially for people who want to have a more relationship-based care experience with their patients. So uh, fundamentally, the difference between um, direct primary care in that model is the payment model. So, whereas with insurance payments, doctors have to get patients in to get paid to bill the 99214s, 99215s, and the reimbursement is typically dictated by the insurance company. Direct primary care doctors get paid on a monthly recurring membership basis to for all-inclusive primary care. So those fees may be paid by individuals in the retail space or by employers. But what it allows is a couple things. One, DPCs typically have a smaller patient panel. They usually see maximum about 600 patients per clinician, where it's about 2,400 patients per clinician in the fee-for-service system. And when I think about who I know, who I'm connected with on LinkedIn or who's in my network, I cannot remember 2,400 people and who they are and what their families and what their names are if I've met them before. And that's what traditional fee-for-service doctors have to do. They're really essentially the continuity of care isn't there, the relationship isn't there because their panels have become so big. Um, and with the smaller patient panel, direct primary care doctors can get to know people, see people for same day, next day appointments. The average in-person appointment time is over 35 minutes, which is a kind of length you typically can't bill in commercial primary care for anyone.
Right.
They usually offer after hours service, same day, next day appointments for urgent care. So it's really, the payment model allows for more relationship based care, more more accessibility, and then ultimately what we've seen from the data that we have better health outcomes, happier members, and for employers, and we can get into how this works for employers, especially self-insured employers,
Yeah.
better cost outcomes in the overall claims experience over time.
Definitely. And I just want to point out for our listeners, there's nothing wrong with traditional primary care. They would probably love to have 35 minutes to spend with their patients. It's dictated by forces beyond their control. And I think it's beautiful that the direct primary care physicians have figured out a way to kind of go back to old fashioned medicine where your doctor knew you, remembered you, and wasn't trying to keep up with 2,400 people's allergies.
Yes, I think that in terms of the scope of care, the education, what primary care doctors can do, it's the same in fee for service or direct primary care, but kind of like you said, the forces of lower insurance payments, more administrative work, kind of very higher cost of labor, things like that have for and COVID was a huge influence in this too, have forced independent primary care doctors to affiliate with hospitals and other corporations. And then when that happens, they get these higher quotas, they get higher patient panels, they have shorter visits, they have more administrative work. And so they do it to keep their practice kind of keep their practice alive and try to help people. And then they get in these situations that are really, really difficult for them to take care of patients well as clinicians. So it typically drives up referrals and prescriptions because those are the fastest ways to help people when you
Yeah.
only have 10 minutes with a patient.
Yeah, that's a good point. Since I've moved to direct primary care probably 4 years ago, I no longer see an OBGYN, I no longer see a dermatologist, I no longer see a urologist, and my DPC is great, and she has referred me out once. She's like, "No, you need to see a specialist for this." But yeah, it's a huge time saver that they're not forced to make that referral just to get you out of the office.
Yeah, primary care doctors they have 8 years of training and experience. They can
Yeah,
take care of most of the kind of entry level things that cardiologist, endocrinologist, dermatologist, um, pulmonologist, and the list goes on are seeing. And so, the movement to specialty care away from HMOs into PPOs, and kind of like these integrated care systems where primary care doctors are essentially just quarterbacking where to send specialty care are really underutilizing what primary care doctors can do. They know how to do almost everything in the book well, and the family doctors can see, babies to seniors. And when you only have 8 to 15 minutes with people, you don't really get to flex those muscles. And direct primary care doctors do. And that's really, I think, really rewarding for them. But it's also really good for patients who truly have a medical home, have to spend less time in the healthcare system. They have more guidance about kind of where to go for various conditions, and also kind of a more holistic look when various symptoms might be going on. And they're not kind of going to one specialist per body part. They have someone to look at it holistically.
Yeah, definitely. So that explains really well the value to the patient, being able to save time, have better, richer interactions, better continuity of care with their physician. What about employers? Where is the value for an employer to consider DPC?
hmm It depends on the type of employer. What we sit in a neat place here at Hint Health, because in addition to Hint Connect, which is the network product that I work on, we support over 3,000 DPC clinics to power their practice, both through membership, kind of their membership management and EMR. And so when we look at the data, we see over half of DPC memberships are sponsored by employers.
Wow.
And I know. And we see all size of employer, all industry. And so they're getting different value out of it. I'll start with, I think broadly what we can say is it's a higher value benefit than most other benefits that you can offer. So whether you're a small business and this is the only thing you offer, or you are a larger self-insured company and you're really looking for something of value, something to get people engaged, offering people what is essentially like a personal doctor or a concierge doctor is a really, really high value, because once people have it, they're engaged with it. We see on average, 70 to 80% of people who have a DPC will go in a calendar year. And so it's not like insurance where, if you don't use it, it feels like you you're paying for something that is just draining your pocketbook. And if you do use it, you might get hit. The experience might not be great and you're hit with a copay anyway. So it's not even very fun to use what you're paying for. With
Right.
direct primary care, it's a high touch and high value benefit that keeps people engaged. Anecdotally, I've heard it improves retention. I haven't seen a lot of data about that. But when we do our member surveys, we see really, really high benefit scores, really high NPS. People generally love the benefit.
NPS, Net Promoter Score.
Thank you. Yeah. And that's the question. Would you recommend this to a friend? And the average net promoter score, I think, for healthcare, I think is around 0 to 10, which is like half the people like it and half the people hate it. So it's like equal. And so when you get up to where DPC is like in the 70 to 80s, what's that is saying is most people would say would recommend this highly, and very few people would tell people to avoid it.
Yeah. So, Beth, you used the word concierge. Can you explain the difference between DPC and concierge? Because I hear a lot of confusion around this.
I think concierge doesn't have one definition. At Hint, when we say concierge, we're talking about a practice that bills fee for service, and then on top of that, they offer a membership fee for enhanced care experience. We differentiate direct primary care from concierge because DPC doctors do not bill claims on top of their membership fee. The price point is usually different too. Typically, when we say concierge, you're looking at $300 and above for a monthly membership. With direct primary care, the average nationally is about 80 for an adult. So it's a much lower much lower membership fee for concierge. But the benefits, I would say, are pretty similar. So you're looking at a doctor who has a small patient panel, who knows you, who's very accessible, who's going to take the time to listen to you, and kind of treat you like a member of their family. So from a benefit side, they're pretty similar.
Yeah. Okay. So sounds like it makes a lot of sense both for the employer and the employee, but how does it integrate with existing health plans like PPOs, high deductible plans, reference based pricing, even self funded?
That's a great question. And I think when you're talking about integrating it with the benefit plan, there's one other point that I'd make on the benefits, which is that when people are going to direct primary care, typically where they're not going is the emergency room, urgent care. There are fewer inpatient visits, specialist visits go down, even prescription drugs, lab, imaging. DP employers typically see reductions in both spend and utilization in those categories. So even for the DPC fee, it's usually double to triple what employers are paying if they look at just their primary care PMPM line. But overall, we typically see it's cost neutral or cost savings for self-insured groups. So that is another huge benefit for those larger groups that may be self-insured, and kind of on the hook for the whole dollar. In terms of how those employers are integrating it with the rest of their package, I see, with Hint Connect, we work with over 50 employers, and we have a mix right now of PPO and unbundled reference-based pricing plans. Across it, the intensity of how much the DPC has to know about the rest of the plan varies based on what type of plan it is. But generally, because all of the DPCs are independent, they're not part of a hospital system, they can help optimize the rest of your plan to write referrals to, the lowest cost, whether it's mid kind of ancillary imaging lab or specialist or hospital systems to save money in the rest of the plan. If there are other direct care vendors like, Green Imaging or HealthMe or kind of any of the other great direct care vendors that help find direct prices at kind of for cash pay rates, DPCs can have knowledge of those and refer to those. So it can be integrated in really any type of plan. For 1/1/26, the One Big Beautiful Bill allows DPCs to be integrated with HSA eligible high deductible plans. There used to be a conflict or kind of a lack of clarification that DPC could be a second health plan, which is not allowed with those types of plans. So I suspect we're going to see really a boom in DPC plus HSA eligible plans because there really isn't that good first dollar coverage in those plans. People tend to be underutilizing care because of the high out-of-pocket burden. And with direct primary care, I think one thing I didn't mention up front that's super important to know is there's not a cost when you see the doctor. So when I mentioned unlimited care, whether you go in person or it's a virtual visit or a phone call, members are not on the hook for even a $5 or $10 copay. It's completely free. So anywhere where there's cost sensitivity, and I think there's always a lot of cost sensitivity on an HSA plan. It's a really good pairing.
Yeah, most definitely. When you remove those barriers, it helps people make better choices and their DPC can really help guide them. It all gets better. And especially on those high deductible health plans and for our self-insured or partially self-insured employers, the ability to keep those minor claims off your, reports is always helpful.
Yeah. And what I would say is, you know, what we do always recommend that if you have DPC, you have some catastrophic coverage.
Oh,
And
yeah.
that may look different for different size employers. For small
Mhm.
employers, they may not be able to afford anything else. They may have people going out and buying their own coverage get coverage through Medicaid, through the healthcare exchanges, through health shares, whatever it may
Mhm.
be. So that may be what catastrophic coverage looks like. But sometimes I'm asked, does this replace an insurance plan? No, it's just the primary care component, but it can pair with almost any insurance plan as long as it's not like an HMO or a closed network where the primary care doctor has to be a named primary care doctor network. So I'd say that is one area of conflict.
Yeah. Do you run into health plans that will let you carve out the primary care benefits if you have DPC in place?
I have not seen that. Having worked at a health insurer, I think that would be pretty difficult and a pretty
Yeah.
unique ask. What I do see is on unbundled plans, typically with a reference-based pricing vendor, you can buy kind of that RBP offering for specialty and facility care, and then you can buy a front end kind of professional network on top of that,
Ah,
and you can forego that front end professional network if you have direct primary care.
okay. Makes
Yeah.
sense. And then, as far as attempting to implement this, what does a successful rollout look like from budget to contributions to communications?
Yeah, I know I keep saying this, but every employer is different.
Yes.
W It really depends on so in terms of budget, what I typically see is the employer will pay the DPC for the cost of the membership, and in some cases, they may do a payroll deduct to offset the cost for themselves. Usually, when I see an employer who's interested in DPC, they're pushing people into it so that that payroll deduct is usually smaller or doesn't exist, but that is a way for employers to kind of hedge against the overall cost of the benefit. So that's one thing to consider. In terms of the rollout, it depends on, the employer's own communication strategy with their employees. DPC does require good member messaging. You're asking people to elect a new primary care doctor, and
Mhm.
it's not a passive benefit. You want people to go in within the first month or 2 months of having the benefit and meet the doctor to carve out an hour or more to actually be in an appointment, which is a length of time. Most people have never been in front of an actual doctor who's talking to them for an hour.
Only in the waiting room, never
Only in
actually
the
in the exam room.
yeah, only in the ER waiting room has anyone sat for an hour. And so, you're asking people to change their behavior around primary care. And so you do have to message that. I would say most TPCs who are working with employers, and are certainly with Hint Connect, we have messaging that employers can plug into their own channels. We support everyone from, white collar, everyone's on emails, Zoom meetings, people are dispersed to companies that where people don't even have company emails and they may not have smartphones. It's all phone based, or all the messaging has to come kind of through manager channels or kind of local distribution channels. So the messaging strategy can differ, but there does need to be messaging during open enrollment. Um, Best case scenario, you get a DPC at an open enrollment meeting so people can actually
Mm.
meet the doctor face to face and see, with typically there's no clinicians at open enrollment meetings, and they're able to explain their practice, why they're practicing that way, how they deal with interact with members, and really have it come off the page to recognize that this is a differentiated benefit. Um, in terms of, I know I said I'm sitting kind of like on the technology and network side. So
Mhm.
when we do implementation for a client, and any doctor who's using Hint technology does implementation, you're typically needing to send over enrollment files or eligibility files, make sure people have their provider selected. But then our technology will manage paying the DPCs, keeping those memberships um, in line with what employers are sending over with enrollment files, aggregating monthly payments, aggregating any ancillary charges that may happen. DPCs typically get extremely low rates for labs, in-house dispensed medications, even vaccines. And so typically what I see is self-insured employers like to take advantage of those rates DPCs can get and have those billed through on monthly invoices. And in some cases, I think DPCs work with TPAs to get paid and have that enrollment process happen. In other cases, it's directly with the employer. But usually there's some combination of, someone at the DPC, someone at the employer on the HR side, and someone at a TPA coordinating that monthly cycle of enrollment and payment.
Yeah, and I'll just add from the employer perspective because we use Hint Connect to facilitate our DPC program. And when we started, we had employees in 3 different states, and so then, of course, multiple DPCs, and you guys make it easy. I only have to pay 1 invoice. There's no way I would pay 6 different practices every month. I don't have the time to do that. So it does make it super easy. And the other thing that I really appreciate is while the technology is all amazing, I can also pick up the phone or shoot an email and talk to a human,
Yes.
and they will very quickly take care of it. So
Yeah,
it's
I
really easy.
appreciate that. I'm really glad to hear that. And on my team, I really value good customer service. I feel like I'm kind of old school, and that is the ethos that we bring to all of our clients on Hint Connect. That there's a person here who's going to help you. So we have an amazing team now. We'll be expanding that team to kind of meet the demand, but that's the service that DPCs provide their members. And so we feel like, of course, that's the service that we have to give to our clients as well.
Yeah, for sure.
So,
On the flip side of that, are there any mistakes that you see employers make that we can help them avoid in rolling out DPC or even evaluating it?
so I think in terms of evaluating, it can absolutely freak CFOs out to see see a monthly fixed cost for primary care that is
Yeah.
more than what quite a bit more than what they're spending today. And I completely understand that. It is you have kind of really have to believe in the cost mechanisms that I mentioned before about investing in primary care and taking spend out of the rest of the system, and it can take several months for those results to accumulate. I would say I see employers sticking with DPC for a long time. The retention rates, especially among larger employers, are very high. People who implement DPC are not losing their shirts on DPC. They're not adding $50 or $60 PMPM to their overall costs when they add DPC. They see that balanced out by lower claims costs. But if you can't get that message through to all of the decision makers at an employer, it typically looks like an added cost that usually people can't afford. So I would say that's the number one mistake in evaluating DPC. The number two mistake is assuming that people have the same primary care bonds that they did 10 years ago. So when I worked at a health insurer, the number one thing when we got a new self-insured group on that we had to do was make sure we had all the PCPs that the group was already using in our network. There has been so much kind of early retirement, people primary care doctors leaving the workforce, replacement of primary care doctors with kind of team-based care where it's not relationship-based because of this primary care shortage and the market dynamics we mentioned earlier, that a lot of people who did hold a long-term primary care relationship close have lost that in the past few years. And so we usually see about 50% of people in year one willing to sign up with the DPC when it's offered optionally. And I would say of those people who don't, maybe half of them have a doctor they already like and are using, and half just don't think they'll use primary care. So that is a common misconception I see, especially for people who've been in the benefits or HR space for a long time and like essentially need to update their model of how people are accessing primary care. Yeah. In terms of implementation, I think we try to, set all of our groups up for success. So we have a model that is about like the education, several member touch points, being at all the open enrollment meetings, getting people on site. But I think the two things when there are challenges, what I see are one, setting expectations about what direct primary care is. So you are asking people to go in and have an appointment. These are doctors who are going to spend more time with you. They're not going to just write you a referral for your meds. They're going to ask you what your underlying root causes are, and often, talk to people about lifestyle changes, and that is not for everyone. And I would say that's not necessarily holistic medicine or what Eastern medicine or functional medicine. That those are basics of primary care that just
Yeah.
don't happen because there's not the time for them to happen in traditional primary care. So, that can be jarring for people who have just been in this really, really transactional primary care type relationship for a long time. The second mistake is sometimes I'll have brokers just say, let's just get in with this group. Even if we sign up 2 people out of 100, let's just give them a taste of it and then it'll work. And that having it as a passive benefit doesn't really work. You have to do that education. And when you have just a couple people sign up, eventually the employer's going to go, nobody's signing up for this benefit. Like it must not be really popular when you really haven't given it a fair shot with kind of the education and rollout. So I see as kind of, when it's really just limping along and there's a few people enrolled, it doesn't usually last for an employer.
Yeah. And then how do you overcome that? Do you have the few people that are on it maybe tell their story in a quick video and share that with the team? How do you spread the good news?
I think bringing the DPC back to the meeting and giving people the chance to either whether it's on site or via Zoom, giving people a chance to do those meet and greets and see what the benefit is about and do the re-education. Not everybody wants to talk about their experience in healthcare with their colleagues. So
Yeah.
if I have not taken that, asked the 1 or 2 people at groups like that if they're interested, usually trying to re-engage with the HR leadership team to talk about priorities is a strategy, but we have not successfully, that's only happened to us, I think, once or twice. We haven't successfully turned the corner with those. So I think just doing it right from the outset is the best way to do it.
Yeah, that makes sense.
Oh.
Well, Beth, this has all been amazing. Are there any things that we didn't cover or any last pearls of wisdom that you would leave to employers?
One thing that I would mention, just because we recently looked at it, is direct primary care is a newer type of model of primary care. Doctors, I think the earliest doctors who were practicing in this model probably started about 15 years ago, calling it direct primary care. And so we see the number of DPC offices growing by about 25 to 30% year over year, even as the movement has gotten bigger. So when I
Wow.
started at Hint 6 years ago, we had fewer than 1,000 clients or kind of client locations. Now we have over 3,000, and we're just part of the market. So I would say if you haven't heard about it, that's okay. It is a new concept for a lot of people, but there's a lot of great information out there about it, DPC for employers on the internet. And then if you looked at DPC a couple years ago and you didn't see anyone in your area, or you didn't feel like, the options that you had were right for you, I would urge people to take a look again this year and next year. The landscape is rapidly changing. And whereas fee-for-service primary care is not growing in step with the way the population is growing, DPC is outpacing it. So it's an exciting time to be working in direct primary care. And if anyone has questions, I would be happy to, continue the conversation or point them toward resources.
Awesome. Well, thank
Yeah.
you so much for your time, Beth. And thank you for being a great partner with Generous Benefits and making it easy for us to offer DPC to our team.
Well, I feel the exact same way about your team. You guys are wonderful. So thanks for the opportunity to chat today. I really appreciate it.
Thanks for listening to Generous Benefits. Huge thank you to Beth Holmes for breaking down direct primary care in practical terms. And if you want to integrate DPC into your health plan or even as a standalone, the Generous Benefits team can guide you. Thanks for listening. We'll see you next time.